Around the world, a quarter of babies born alive are either born too soon or born too small, leading to a higher risk of dying during early life and causing long-term reductions in health, growth, and development. In Zimbabwe, at least 1 in every 10 babies is born too soon, and the chances of a preterm birth are even higher in women living with HIV. 1 in 7 pregnant women in Zimbabwe are living with HIV. Preterm birth is now the leading cause of under 5 child mortality around the world. We urgently need to find new ways to keep women healthy during pregnancy and reduce the chance of babies being born too soon or too small. Infections during pregnancy can prevent the baby from growing healthily in the womb or can trigger early onset of labor, leading to preterm birth. This means that starting a pregnant woman on antibiotics during pregnancy might protect her from getting infections and could reduce the number of small vulnerable newborns. The COMBI Trial in Zimbabwe tested this theory by enrolling 1,000 pregnant women when they first attended the antenatal clinic and randomizing them to receive study medications, either a daily antibiotic called Cotrimoxazole or a placebo that looked and tasted the same. Cotrimoxazole prevents a range of infections and has anti-inflammatory effects, meaning it can reduce an overactive immune response. Both these actions of cotrimoxazole could be beneficial during pregnancy to help the baby grow and to prevent the onset of premature labor. The trial was conducted in 3 antenatal clinics in Shurugwi district, where 1 in 7 pregnant women are living with HIV. We undertook an ultrasound to accurately calculate the gestational age. We collected blood samples, stool samples, and swabs from women during pregnancy to understand the types of infections they had and whether cotrimoxazole works by reducing infections and inflammation. At each antenatal visit, women received iron and folic acid to take daily until the next visit, and any other treatments they needed during pregnancy. In addition, they were provided with study medications and were asked to take 2 tablets every day. Neither the women nor the research team knew whether they were receiving the antibiotic or the placebo tablets. Overall, the tablets were well tolerated and the women had high adherence to the medication. We compared birth outcomes between the 2 groups to see if cotrimoxazole reduced the number of small vulnerable newborns. This included the birth weight of the baby, gestational age at birth, and the number of preterm babies in each group. We found that the birth weight of infants in both groups was similar, but women receiving cotrimoxazole had pregnancies that lasted half a week longer, and the number of preterm births was 40% lower than in the placebo group. In the cotrimoxazole group, 7 out of every 100 women had a preterm baby compared to 12 out of every 100 in the placebo group. Among women living with HIV, the benefits of cotrimoxazole seemed to be even greater. On average, pregnancies were almost 1 week longer, and the proportion of preterm births was almost 90% lower than in the placebo group. In the cotrimoxazole group, 2 out of every 100 women had a preterm baby compared to 14 out of every 100 in the placebo group. Women with HIV who had taken cotrimoxazole tablets during their pregnancy also had bigger babies than women who had taken placebo tablets. There was no evidence that taking antibiotics during pregnancy had caused any harm to mothers or infants. So what does this mean for pregnant women in the future? Cotrimoxazole may be one strategy that can help to prevent the high preterm birth rates in Zimbabwe. Cotrimoxazole is a low-cost antibiotic which has few side effects and is already available in most rural clinics because it is often used in people with HIV to stay healthy. However, we need to find out whether widespread use of antibiotics would lead to more antimicrobial resistance in pregnant women and their infants. We also want to understand the long-term effects of antibiotic exposure on growth and development as children get older. This is important before deciding whether cotrimoxazole should become a routine part of antenatal care for all women. The striking effects of cotrimoxazole in improving the birth outcomes in women with HIV mean that policymakers should consider introducing cotrimoxazole now as a routine part of antenatal care for this group. Pregnant women with HIV who are not currently taking cotrimoxazole when they register for antenatal care could start it during pregnancy to reduce the risk of having a premature baby. In Zimbabwe, starting 8 women with HIV on cotrimoxazole during pregnancy would prevent one preterm birth, meaning it could have a huge impact if scaled up across the country. We now need to know if cotrimoxazole has similar benefits in other countries and whether the reduction in small vulnerable newborns that we found in COMBI leads to long-term improvements in child growth and development. If so, then a low-cost antibiotic once a day during pregnancy could reduce the risk of preterm births around the world and help children not only survive but also thrive.